just introduce our next speaker. Our next speaker is Yvonne Bailey. She is currently a CNM2 and clinical nurse specialist in inflammatory bowel disease in Tallaght University Hospital. She provides a specialist inpatient and outpatient service for patients with inflammatory bowel disease. She's completed a master's in research in Trinity and a postgraduate higher diploma in gastroenterology in UCD, and she has several publications in European and international journals. Today, she's going to give us an overview of inflammatory disease.
Good morning, everyone. I'd like to thank Fiona for the invitation to speak at the National Telephone Triage Conference today. I will present an overview of inflammatory bowel disease, covering presenting symptoms and treatments. Thank you. Inflammatory bowel disease describes a group of conditions in which the intestine becomes inflamed. Two of the most common inflammatory bowel disorders are Crohn's disease and ulcerative colitis. IBD is a chronic condition characterized by periods of relapses known as flares and remission. Crohn's disease can affect any part of the GI tract, from the mouth to the anus, and may involve full thickness of the intestine. Ulcerative colitis only affects the inner lining of the large bowel. Crohn's and ulcerative colitis may present with similar symptoms, but the distinguishing features between them are ulcerative colitis affects the mucosa of the large intestine, the mucosal layer becomes inflamed, there's bloody diarrhea, and it's a continuous involvement. With Crohn's disease, there's patchy transmural, which is full thickness of any part of the GI tract. You then get segmental lesions, which are skip segments of inflamed and non-inflamed bowel. With the inflammation, then the bowel becomes stenose, which are narrowed sections. There's granulomas present in Crohn's, but not in ulcerative colitis. You may have deep abscess formation and fistulae. This slide shows the areas that are affected by Crohn's disease and ulcerative colitis. On the left-hand side of the slide, you can see Crohn's disease. There is about 45% is ileocolonic involvement. There's about 33% which is actually terminal ileal disease, and only about 20% colonic disease in Crohn's disease. With ulcerative colitis on the right-hand side, you can see there is it's an extensive involvement where it is a continuous involvement and can involve the entire intestine, which is then known as a pancolitis. There are 2 million people in Europe who are affected by inflammatory bowel disease. The incidence in Ireland is approximately 40,000 people living with Crohn's or colitis. In Crohn's disease, there are about 5.9 new cases per 100,000 of the population. In ulcerative colitis, there's 14.9 new cases per year per 100,000. The peak occurrences of both diseases is between the age of 15 and 35, and there's also a secondary peak between 50 and 70 years. IBD also affects children, and there are cases that have been recorded in babies as young as 6 months old. There's about 10% of IBD cases are recorded in individuals who are less than 17 years of age. The cause of inflammatory bowel disease is unknown. There is a genetic susceptibility, and there are a group of genes which have been isolated and show a strong association with Crohn's disease and ulcerative colitis. There's also ongoing studies to look at gene profiling for better management strategies, i.e. more aggressive genotypes may start biological treatments earlier. There are about 15 to 20% of patients with this condition have a relative with IBD. Children born to parents, so that's both parents with IBD, have a 33% increased chance of developing the disease by 28 years old. Diagnosis of IBD in childhood appears to be a much more aggressive disease, so familial incidence of IBD, a positive family history, outweighs all other risks. Other factors to consider is environmental factors. These may be triggers or exacerbate the disease. Smoking, for instance. Incidence of Crohn's disease in smokers is much higher than in ulcerative colitis. We often see patients presenting with ulcerative colitis after giving up smoking over the previous number of months. So I suppose the question is smoking a protective factor in ulcerative colitis? Periods of stress in life, I suppose, leaving cert, death, any of those show an exacerbation actually of disease. Non-steroidal anti-inflammatory drugs, history of appendectomy, history of infection with myobacteria, activation of the immune system, and possibly diet. So certain foods may exacerbate a flare, but diet has not been proven to be a causal effect. The main symptoms of inflammatory bowel disease are diarrhea, which sometimes can be mixed with blood, mucus, and pus in the stool, abdominal pain, which can be severe and often occurs while passing a stool, tiredness and fatigue due to illness itself, anemia, side effects of the drugs that are prescribed for IBD, or lack of sleep due to pain and diarrhea with overnight bowel movements. Fever, loss of appetite and loss of weight from not absorbing nutrition due to inflammation in the gut, anemia particularly in Crohn's, developing complications including strictures, which are ongoing inflammation may cause scar tissue which creates narrow sections of the bowel which leads to stricturing disease. Fistulas. A fistula is an abnormal channel or passageway connecting one internal organ to another or to the outside surface of the body, and these are more commonly seen in Crohn's disease, and other extra-intestinal manifestations. There are other manifestations seen outside the gut, which can affect several of the body's systems which are associated with IBD. Within the musculoskeletal and dermatological systems, there are seronegative spondyloarthropathies, psoriatic arthritis, and ankylosing spondylitis. In the hepatobiliary system, primary sclerosing cholangitis, which is known as PSC, cholelithiasis of gallstones, drug-induced pancreatitis, and drug-induced hepatotoxicity. These are usually associated with immunosuppressant drug therapy, one of them being Humira, and normally when we commence these drugs, we do monitoring of bloods very closely to watch out for toxicity. The ocular system then, scleritis, uveitis, conjunctivitis, and iritis. In the renal system, nephrolithiasis, kidney stones, obstructive uropathy, fistulization of the urinary tract system, which is seen in fistulizing disease, usually in Crohn's, pulmonary, chronic bronchitis, bronchiectasis, and bronchiolitis. When a patient presents with pain and bloody diarrhea, we need to rule out infection, so we collect stool samples for ovarian parasite, culture sensitivity, and C. diff. We also look for markers of inflammation. We do bloods, looking at the CRP, C-reactive protein. High levels may indicate inflammation of the bowel. Fecal calprotectin, which is a stool marker for gut inflammation. Any imaging investigations that are required: colonoscopy, sigmoidoscopy. These are good for examining the large bowel ileum and enable biopsies to be taken. Capsular endoscopy, which allows video recordings of bowel, is actually a good test for small bowel disease. CT scan, enterography, MRI, and any other investigations required. Over the next few slides, we will look at how we manage the symptoms of inflammatory bowel disease: diarrhea, abdominal pain, rectal bleeding, fatigue, and weight loss. In acute diarrhea, antidiarrheal agents are contraindicated as the diarrhea could be infectious and the risk of precipitating a toxic megacolon in ulcerative colitis. In chronic diarrhea, we use antidiarrheal agents, Imodium, Lomotil. Diarrhea after ileal resection or an ileostomy, which is bile salt diarrhea, so we use resins like Questron. Monitor for dehydration. If diarrhea is severe, we replace fluids, electrolyte replacement, and we may try a low residue diet to decrease the output. In the management of rectal bleeding, we need to identify the cause. If it's inflammatory, we would treat with topical steroids or 5-ASAs, possibly suppositories or enemas. If it's infectious, so C. diff, or salmonella, we would use antibiotic therapy. In managing abdominal pain, we need to rule out symptoms of exacerbation of IBD or complications of IBD. Obstruction due to stricturing disease, there may be nausea and vomiting. With perforation, there may be symptoms of acute abdomen, and with abscess, the patient may present with a temperature or fever. In controlling pain, we use analgesia. Narcotics are generally not used, but some patients do use long-term low-dose narcotics. Use of non-steroidal anti-inflammatories should be used cautiously, as this may provoke GI inflammation, and then consider alternative treatments such as acupuncture or yoga. Fatigue and loss of well-being. Some of the possible causes are circulating inflammatory cytokines, nutrition deficiency due to malabsorption and malnutrition, iron deficiency, low B12 and poor vitamin intake, low testosterone levels, depression, poor sleep quality due to pain and possibly nocturnal bowel movements. So we advise patients to look at their lifestyle factors that can help. So with rest, we advise the patient to take as much rest as possible, some daily low impact exercise, nutrition, to have a varied diet as much as possible, and stress reduction. Looking at weight loss, we need to identify causes. Reduced appetite, just not eating enough due to poor appetite during disease activity. Fear of eating, associates it with increased diarrhea and increased pain. Malabsorption due to inflammation. Address any vitamin and mineral deficiency, so low B12, low folate or zinc. Correct any iron deficiency, so we give oral iron supplements or an iron infusion if necessary. Nutritional support, so total enteral nutrition or total parental nutrition. These are the medications we usually use in inflammatory bowel disease, usually starting with steroids. We use prednisolone, hydrocortisone, budesonide and cortimant. The 5-ASA immunosuppriments group, we use azacolon, pentasa, salifalc and mazavant. Immunomodulators, azathioprine, 6-MP, methotrexate or cyclosporin, not really used nowadays. Biologics such as infliximab, adalimumab, ustekinumab, golimumab, vedolizumab, which is a new gut-specific biologic. And then in the new era of biosimilars, we use Remsima, Hulio, and Amjevita. Corticosteroids used in Crohn's disease is very effective for inducing remission. Used in ulcerative colitis, rectal steroids for inducing and maintaining remission, oral corticosteroids for inducing remission. We usually use oral prednisolone with a dose of 40 to 60 milligrams per 1 week, and those are tapered by 5 milligrams weekly. Oral budesonide 9 milligrams daily, and we may use IV prednisolone if the patient is admitted. Steroids have no role in maintenance therapy. They do not lead to mucosal healing, so are used on a short-term basis. Some of the potential serious adverse events when using corticosteroids are opportunistic infections, avascular necrosis of the femoral head, cataracts, osteoporosis. Patients should receive calcium and vitamin D while we are prescribing corticosteroids, acute adrenal insufficiency, myopathy, behavioral changes, worsening of HTN and BG, and glaucoma. This is just a reminder that when patients are on steroids, they must also be prescribed calcium and vitamin D supplements, and also a DEXA scan is suggested. Corticosteroids are induction therapy but not maintenance therapy. Beware of steroid dependency. Course of treatments should last for 8 weeks. Beware of risks of mental health issues, mood changes in patients who are on steroids. This slide is just a reminder for steroid tapering therapy. It's usually recommended for patients with inflammatory bowel disease flare-ups that they commence steroids at 40 milligrams, tapered by 5 milligrams over 8 weeks. We see sometimes patients in the community being prescribed steroids from 30 milligrams for a week, which I think is probably used more so for respiratory conditions. Prior to starting immunosuppressant therapy, it's important to exclude active and latent infection for TB, confirm immunization status and vaccination history. It is important to inquire about future travel. With traveling opening up worldwide, there may be a possibility for a live vaccine needed in certain countries. Bloods, we do full blood count, ring, liver, bone and C-reactive protein, and then monitoring of bloods. We do weekly for 4 weeks, monthly for 3 months, and then 3 monthly thereafter. Some of the common immunosuppressions that we actually use are azathioprine or Immuran and 6-mercaptopurine, which sometimes is known as 6-MP. Its role in Crohn's disease are effective inducing and maintaining remission. The steroid-sparing effect for azathioprine and 6-MP when inducing remission, and for azathioprine when maintaining remission. Its role in ulcerative colitis, it may be effective in maintenance therapy for patients who fail or cannot tolerate mesalazine or sulfasalazine, and those required to repeat courses of steroids on multiple occasions. Side effects are nausea, vomiting, rash, alopecia, fever, arthralgia, diarrhea, and steatorrhea. The serious side effects are bone marrow depression, leukopenia, thrombocytopenia, opportunistic infections, pancreatitis, and hepatotoxicity. There is an increased risk of leukemia and lymphoma with these drugs. Methotrexate, its role in Crohn's disease. It's usually prescribed at 25 milligrams per weekly as a subcut, and it can induce remission and complete withdrawal from steroids. 15 milligrams can maintain remission. No evidence for lower oral dose methotrexate to induce or maintain remission. Its role in ulcerative colitis, On the basis of minimal data, there's no evidence to recommend use of low-dose oral methotrexate, 12.5 milligrams per week, to induce or maintain remission. However, it's rarely used now. Side effects: leukopenia, nausea, malaise, fatigue, fever and chills, decreased resistance to infections. Serious side effects are hepatic fibrosis and cirrhosis, interstitial pneumonitis, opportunistic infections, and skin conditions. Vaccines to consider prior to immunosuppressant therapy. Some experts now recommend that we should update childhood vaccinations as appropriate. Polio, tetanus, diphtheria, MMR, and pertussis. Just bearing in mind that the MMR is a live vaccine and these are not indicated while on immunosuppression. The influenza, pneumococcus, hepatitis B, pap smear advice. We recommend generally that people keep their smear tests up to date. And of course, our COVID vaccination, which is recent enough. We're generally asked when to have the vaccination for immunosuppressants when people are actually on immunosuppression or biologics. At the moment, there is no clear guidelines, but we advise our patients 2 days before they're due their subcut injection or 2 days afterwards. And now on to biologics. The longest biologic that we've been using is actually infliximab, or known as Remicade. It was approved by the European Medicines Agency for Crohn's disease in 2001, so we have quite a long period of use for this drug. It's indicated for both Crohn's and colitis. It's been used in over 1 million patients worldwide across all licensed indications. It's delivered by a 2 to 3 IV infusion or as per local policy. These were the initial guidelines, and it is mostly used an hourly infusion. And in our own practice, patients who have 10 infusions and over, it's given actually over half an hour. The induction doses at week 0, 2, and 6, and then maintenance doses are every 8 weeks thereafter. Adalimumab, or Humira, was approved by the European Medicines Agency for Crohn's disease in 2007. It's currently been used in over 800,000 patients worldwide across all indications in dermatology, gastroenterology, and rheumatology. It's a subcut injection available in a preloaded syringe or pen. This is a list of the biologics that are used in inflammatory bowel disease. Adalimumab, which is also known as Humira, is an anti-TNF. It's given a subcut injection. It's given in 160, 80, 40 milligrams at week 0, 2, and 4, and then 40 milligrams every other week. Golimumab, which is also known as Simponi, is a synthetic antibody. It's also a subcut injection. It's given at 200 milligrams, 100 milligrams 2 weeks later, and then 50 milligrams every 4 weeks. Infliximab, also known as Remicade, is an anti-TNF. It's given as an IV infusion at week 0, 2, 6, then every 8 weeks thereafter. This is now also available as a subcut injection. Ustekinumab, also known as Stelara, is an anti-interleukin biologic drug. First dose is given intravenously, then subcutaneous every 12 weeks thereafter. Vedolizumab, or Entyvio, is a gut-selective integrin blocker. It's an IV infusion given at week 0, 2, 6, then every 8 weeks thereafter. The common side effects seen with anti-TNF therapy are local injection or infusion site reactions, redness, rash, swelling, itching or bruising, upper respiratory tract infections, sinus infections, urinary tract infections, cough, headache, rash, nausea and/or vomiting, abdominal pain, and fatigue. The serious adverse events are infections, opportunistic, bacterial, viral, fungal, or reactivation of tuberculosis, malignancy, solid tumors, lymphomas, hepatosplenic lymphomas, demyelination syndromes, and class 3 and 4 congestive cardiac failure. In conclusion, Crohn's disease and ulcerative colitis can have similar presenting symptoms, but on investigation they are histologically different and affect different parts of the bowel. Peak age of occurrence are similar. Smoking is more prevalent in Crohn's disease. A positive family history outweighs all other risks. Treatment groups used in Crohn's disease and ulcerative colitis are the same, but more topical agents are used in ulcerative colitis. Live vaccines should be avoided if immunosuppressant or biologic treatment is being considered. Thank you for your attention.